Hi, my name is Leroy Horton. I am chair of the scientific committee for the National Dental Association. Thank you to Marcus Ware for facilitating and giving us a platform to nerd out on a Saturday morning. And I have the immense pleasure of introducing a good friend of mine, fellow periodontist out of North Carolina. Did her undergraduate degree at University of Maryland in College Park, um, graduating magna cum laude, right? So if there's ever an opportunity to celebrate our friends and hype them up a little bit, we got one of the best here. She did a GPR, or she did her dental school at the University of Maryland, did a GPR in Pennsylvania, and after a few years of general practice, went back and did her periodontal training at University of California, San Francisco, UCSF. And after numerous conversations and talking about what are the best things to give an entire audience of mixed backgrounds, right? So general dentists, specialists, all the expertise that we have in our community. Hannah was gracious enough to come up with an amazing presentation that blends both the perio and the restorative. And so, Hannah, without further ado, I am so proud to have you here. So proud that I get to highlight some of my friends on the NDA platform. So I will give you the floor.
All right, here's my thank you so much, Dr. Leroy. It's just like a complete honor to even be here and just to know you. So just again about me, I was a general dentist first, and I went back to specialize. And just like Dr. Horton, I think that makes you a better specialist. So this is a little bit about me. This is my husband and my daughter when she was younger. She's now at Duke. So I will be working for the rest of my life to help pay for her tuition. And a little bit more about me. So if I look tired, it's because we adopted this guy. He's 8 weeks old and he literally sleeps an hour and a half. His name is Sheldon. He's super cute, but not getting a lot of rest. It's like having a newborn. And more about me, I am originally from Egypt. So we moved from Egypt to Germany, from Germany to New York, and I spoke no English. But I learned to speak English actually watching Sesame Street because all the English as a second language classes were filled up. And so sometimes I'll slip into my little Arabic accent, but this is a picture of me and my cousins and my husband at the pyramids. We went about 6 years ago, and my cousin is really good friends with this guy. He's the head archaeologist of the Egyptian pyramids, the whole footprint. And so we got to go inside the pyramid and climb up to the king's chamber, which is up here. Right now, that's not an option open to the public, but because she was his instructor in German, he allowed us to go up there. And obviously, the new museum just opened up with great fanfare, and I'm just so proud to be an Egyptian always, but especially at this time. So let's talk about how important the correlation between periodontal disease, periodontics, and then restorative. If I could give anybody some advice, is that you need to find a specialist, a periodontist, an oral surgeon, and an endodontist that you have a close working relationship with that's going to have your back. By that I mean, if something goes awry and you need them to back you up, you have that working relationship and a mutual understanding of philosophy. And that's what I have with all my restorative doctors that I work with. So, in order for restoration to survive long term, you have to have a healthy periodontium and vice versa. Defective dental restorations cause the periodontium to be defective as well as cause implant problems. So, I learned in dental school that the final restoration is only as good as your provisional. So, if your provisional is not very good, it's going to impact the final restoration and the soft tissue healing around it. So these are some considerations when you're looking at periodontal and restorative in a relationship. The biological consideration, we'll talk about biological width violation, aesthetic concern, occlusal consideration, and more some important things as marginal ridge discrepancy. If the marginal ridges are on different heights, you're going to have a food impaction site. If the contact length is too small, you won't have a papilla. If it's too big, you may not have a papilla, and I'll go through all of that. So this is a case that was actually referred to me. This is, I hate to say it, is a retired periodontist, and his general dentist did the splint. And he came to see me because he was one, my mentor, one, and two, he could not clean underneath his teeth. And you could see why. It's just a glob of composite. So this will definitely impact his periodontium. So I sent the photo to his general dentist. I said, "Hey, can you help me out and redo that splint?" And he was like, "Why? I see nothing wrong with it." So in that case, I just decided I'm gonna take it off myself. So I removed it and we wind up taking out this tooth. And then he went to a general dentist that I work with immensely. We cut the crown off and then had the tooth splinted. And this is the difference in a well-made provisional splint, which actually in this guy's case becomes his final splint because he can clean underneath it. It's not a food trap. It's not blocking out the embrasures. So let's talk about biological width. And I don't know if everybody learned that in school or not, but you'll have patients that have inadequate biological width or biological width violations. So the way to evaluate that is by looking at radiographs and you sound to bone, which means they're numb, and you take the probe and you go down to bone. You're not just measuring the pocket, you're going down to bone. It's usually deeper. So this was a concept that was attributed to D. Walter Cohen in the Walter Reed Army Medical Center, where Marcus is nearby in 62. But all the literature is attributed to this guy Gargiola, and he did cadaver studies where he measured the average biological width that you need between a crown or a restoration and the bone in order to have healthy outcome. Um, so this is a clinical view of what the biological width would look like based on Dr. Gargiola's studies of many cadavers. This is an average, and in some patients you need more, and in some patients you need less. And even in the same patient, you may need different amounts. But we can talk about that in the question session. So, two methods when you have a biological width violation. So, let me step back and say I'll get a patient that's referred to me that had a crown done and the tissue is very red, there's bleeding on probing. And they say inevitably it feels like there's something between my teeth. And when I floss, it hurts, but it hurts kind of in a good way. Some people also say it feels like there's a potato chip stuck between their teeth. So, you know that there's a biological width violation in that case. Ways to correct it is by doing crown lengthening. You always have to review potentially of getting dock triangle. This is something I do, and maybe other restorative doctors do that too in their office. And in order to get the provisional needs to be done well in order to set the tone for the tissue to rebound. And I'll show some cases. Another option is orthodontic treatment or orthodontic extrusion. So in my 20 plus year career, I've probably seen 3 orthodontic extrusion cases. It tends not to be very common. So these are the indications for crown lengthening. You want to increase the clinical crown height because the tooth is lost and there's no ferrule space. So remember, the retention of the crown is not due to the amount of cement that holds the crown, but how much resistant and retention form there is in the ferrule space of the crown. And you want to relocate the margin if it's imposing on the biological width, whether it's a composite or a crown or an amalgam. So if you see somebody who has consistent redness around all the crown all around, it's probably a biological width violation. You want to do it for aesthetic indications such as short clinical crown where you have altered passive eruption, and I'll show some cases in that. If somebody has uneven gingival margins, so the gingival margin on 8 is slightly more coronal than the gingival margin on 9, and they have a broad smile. Or they have excessive gingival display, and I'll show a couple of cases on that. Dr. Horton, do you want me to stop for questions while we're going or wait till the end? Okay. All right. Anyway, till he gets back to me. So these are some indications that we kind of went over there. If there's decay that's so far subgingival that you're not going to be able to capture it in your crown, there's unesthetic or uneven gingival margins, or there's inadequate clinical crown. The contraindication, if there's deep caries, let's say there's caries in the furcation or below the furcation, that makes it virtually unrestorable. If the root is very short, you don't want to crown lengthen it because you're basically taking bone away, and then the root will be even less bone. And if there's severe root proximity, if the teeth are really tight, example in the lower incisors, it's very challenging to do crown lengthening without potentially nicking the adjacent teeth. All right. Um, Here's different surgical techniques. You can do a gingivectomy where you go in and cut the gingiva off, whether it's with a laser or with a blade. I almost never do that, and I'm sure Dr. Horton will agree that you've got to, as a periodontist, I've got to flap it open. So what I do, I'll flap it open. I'll look at the bone level in relationship to the CEJ, and I'll determine whether I need to take away bone, recontour bone, and again, the provisional sets the tone for the entire restoration. And I'll show you cases where that was not done. So here's a case. There's a patient I had that had crown lengthening. So first thing, you want to make sure they have adequate attached gingiva if you're going to cut away attached gingiva. And then here you're looking at making 8 and 9 on the same gingival zenith as 6 and 11. Oops, sorry, as 6 and 11, and then 7 and 10 a millimeter shorter. And then I lay a full thickness flap, usually from like 5 through 12, and I'll recontour the bone. Again, these are some other clinical indications. This is just a visual review of it. You're treating subgingival caries. You've got root resorption, and I'll show some cases. You need to increase the ferrule space for resistant and retention form, or if you want to aid in restoration, although this case is really pretty hopeless and this tooth is unrestorable. So I talked about this a little bit. Altered passive eruption is another indication for like crown lengthening. This is a condition where the tooth has not erupted through the CEJ and the attachment has stayed behind. And there's two classification systems. I tend to go with the one on the left right here. You've got the dentogingival margin junction is located at the CEJ or above. This is when it's located on the enamel as well as the cementum. Stage 3, it's located entirely on cementum, and this is probably ideal right here, stage 3. And then stage 4, you've got recession and you can see the CEJ. I talked about this before, orthodontic extrusion, and in my career, I've had like 2 or 3 cases where instead of crown lengthening to the tooth, you place a post in the tooth and you extrude it orthodontically. Again, most people tend not to do that because it's time consuming, it's costly. Usually the tooth has to have had endo. Contraindication is that you don't have occlusal clearance because you're basically pulling the root out of the bone and the soft tissue. And in the process, it's really unesthetic. Like you've got this button that's dragging the root out. And another contraindication is inadequate crown to root ratio. So let's get to the fun part and talk about some presentations. So here's a patient that has uneven gingival zenith. She has a very broad smile and a hypermobile upper lip. So I'll step back right now and talk about options for that. You can do filler, you can do Botox, but in my practice, I have a Fotona laser, and I did in this case lip lase where you with a laser, and it's the Nd:YAG portion of my Fotona. I increase the lip volume, and I'll show that. So here she is. This is at the time of the surgery. I want to get 8 and 9 on the same platform, and 7 and 10 already are, and 6 and 11 are. So basically, I'm just going to do scalloping on the facial of 8, full thickness elevation, recontour the bone and approximately, and then do positive architecture to get the tissue to lay down. And so here it is after it's completed. And then you see here, I did lip lase, which is a way of plumping up the lip, but it can also be done with fillers or people use Botox. Or there's another technique called a vestibular lip revision. I don't do that. This is a minimally invasive treatment with the lip laser that's done like 2 or 3 times. Next case is a true case of altered passive eruption. So the patient, a lot of these patients, what happens is they have a lot of spaces between their teeth, and then the orthodontist will bring the teeth together, and all that tissue that was interproximal will pile up on the facial of the surfaces. So in this case, she finished ortho. She really wasn't that happy with the result. She's like, my teeth aren't that bright. Yeah, they're straight, but they're not that bright. And if you look really carefully, she has a concavity here on the facial of 8 and 9. So she was sent to me to do surgery. And here I have done what I told you before. I've scalloped the tissue and laid a full thickness flap. But you see, she's got all these buccal exostosis. If I just cut the tissue away and didn't lay a flap, the tissue will over time rebound back because, again, the bone sets where the soft tissue will close. So I recontoured the bone and I did like fluting, like we learned in dental school, kind of like you festoon or denture. And then here it is closed the day of the surgery. I also did a frenectomy. So you see here are those grooves that she had. Then here's her final result. She wound up having like veneers on 8 and 9 and bleaching her other teeth and then like reshaping and composites on the lateral. So it's just a very nice aesthetic result. And I just took that little bit of gingival and periodontal and restorative interaction to get the result that she was really looking for after ortho. So this is again comparison before and after. These are like one of the best surgeries to do because the instant you sit the patient up to look, they literally start crying because it's an instant result and they see it right away. Okay, so let's talk about papillas and embrasures. If your papilla is too wide, I'm sorry, if your embrasure is too wide, you're going to have a flattened and a blunted papilla. By that I mean, if your embrasure is in the incisal 1/5, the papilla is not going to come back. If your embrasure is too narrow, you're basically squeezing out the papilla and it's going to be inflamed. So the ideal embrasure is to allow for a healthy and pointed papilla. And all of us have heard about the Tarnow rule, but I'll go over it in a little bit. The papilla height is related to the level of the bone, so the Tarnow rule of 5 mm. If there's a biological width, an embrasure form is based on the type of tissue you have. If the tissue is very thin, you have very little wiggle room. It's not as forgiving as if you have thick fibrotic tissue. So this is your ideal embrasure. The contact is between the middle of the two teeth, and you're within 5 mm of the crest of the bone. So if you draw a line from here to here, it's 5 mm. And the next slide will show that for every millimeter you are away from the crest of the bone of 5 mm, you're going to progressively lose the papilla by 50%. So let me go back to this slide. So let's say the contact is from here to here. So you're more than 5 mm away. This papilla will be blunted by 1 mm. This also holds true for implants, but we'll talk about that in a minute. So the Tarnow rule basically is explained right here. That the implant, the principles of papilla formation around natural teeth also applies to formation between implants and natural teeth. So the implant needs to be straight in the middle of that socket, not pushed to one tooth or another. Square teeth have a wider contact and are less likely to develop black triangle, whereas triangular teeth, or the contact is at the very crest of the incisal edge, you're going to have blunted papillas. So again, let me go back to this slide. This is just an important slide to remember that you want to be between your contact between 5 mm or under to the crest of the bone. Any further up, you will lose this papilla height. And actually, some of my restorative doctors, when they write a to lab slip, they tell them that the lab, especially for a crown on an implant, you want a broad, flat contact because that'll help the papilla fill back in. Okay, so these are classic examples of dark triangles. You hear there's no contact here, so the papilla is gone. This one is intact. This one you've got the contact is at the incisal edge. So you see the length of the dark triangle. Again, square teeth are more forgiving versus triangular teeth. Triangular teeth, you'll have point contact in the incisal edge, but not in the body of the tooth. This contact is correct, but the patient's had bone loss, and so you have all the recession. You see here the CEJ of the adjacent teeth, and the bone is up here. That's about 7 or 8 millimeters, so you're not going to have no dark triangle. And if you're doing periodontal surgery, that patient needs to be warned about that. So this is one of my cases. I'm sorry, the slide is a little blurry. I did crown lengthening and frenectomy, but ahead of time, I knew that she would have an open contact, and I warned her about that. So after she finished the crown lengthening with me and healed, she went back into a Holly, and they pulled these teeth together because the contact was open because she had that frenum pull, and it wasn't addressed before she finished ortho. So now that the frenectomy was done, she went back into a Holly. They closed the contact and they actually splinted 8 and 9 together on the lingual. So let's talk about where your restorative margin should be because that really has an impact on the gingiva. Ideally, you want to have supragingival margins. So that's not always possible in the anterior, obviously. In the posterior, you may be able to get away with it. Or having it at the gingival margin, equigingival. Subgingival, you run the risk of a biological width violation. But if you're going subgingival because there's decay and or you need more tooth structure to grab, then you might want to consider having crown lengthening done before going to the final restoration. So let's talk about provisionals. And for us as periodontists, this is one of the most critical steps in dentistry is if the restoration will be mimicked by the provisional or vice versa. So if your provisional is well done, well polished, the tissue is going to rebound, but it's impossible to ask the tissue around a poorly fitting provisional with cement around it for it to heal properly. Um, so I'll show a case in a second. The provisional is there to manage the tissue, to verify comfort, phonetics, and aesthetics, to ensure cleansability, to meet the patient's aesthetic demand. This is basically a blueprint of what the final restoration is going to be. So again, most importantly, the provisional is a template for your final restoration. So I'll get a patient, let's say number 12 is broken, the lingual cusp is broken, and I'm asked to crown lengthen it. There's no provisional on it, or they put some composite. So what I'll do is I'll do my crown lengthening, and then I'll write my restorative doctor back. Please get the patient back for a full coverage provisional to allow for best tissue healing. Please wait for 4 weeks to finalize the provisional and then another 4 weeks for the final restoration. That's usually my protocol in my practice. I don't know what Dr. Horton does, but maybe he can talk about that in a question session. So let's go through some more cases. All these cases are my cases, and I have a lot of side stories to tell, and hopefully I can get through some. So this patient was sent to me. She had crowns done that were 15 years old, and she had a gummy or wide smile, and now she's had recession happen on the teeth, and now they wanted to redo the crowns. But as you see, her teeth are already pretty big. So she was sent to me to do soft tissue grafting. And I was more than happy to do it, but I wrote the prosthodontist, can you please put her in provisional so I know where you want your margin to be? Um, do you want these to be the same size? I just needed some feedback. So he puts her in a provisional, but unfortunately, the provisional was one block from 7 through 10. ideally you want it to be individual crowns. I know it's easier to do it as a block, but it makes the surgery for the periodontist that much more challenging because I'm trying to guide this papilla back, but the contact you see is just one broad flat contact and the tissue can't be like manipulated to it. So is it cleansable? It wasn't really that cleansable for her. So what, here's the incision, like my incision for the connective tissue graft, if in case anybody hasn't seen it before. And then here's like a sample of what a connective tissue graft looks like. So this is her, the crowns were cemented, but you see she has marginal inflammation. To me, I would have loved to have seen this look a little bit pinker like this, but for in her standpoint, she was really happy. So the connective tissue grafts were done on 7, 8, 9, and 10. I had to remove the block provisional and do my connective tissue graft suture and then re-cement the provisional as a block. Had she been in individual temporaries, I wouldn't have had to do that. And so this is her at maximum smile. When we compare, compare before and after, it's a pretty nice aesthetic result. Again, she was getting these crowns redone because she had initially had them done 15 years ago because she had tetracycline stain. So I'm starting to see a lot of this. Patients that are on Ozempic, they will lose a lot of weight, a lot of really connective tissue around their mouth, and you know they have the Ozempic face, and you'll also have the Ozempic mouth. You'll see this patient had a bridge that was from 7 to 10, but with all the weight loss, she lost volume here, and she was starting to spit through her teeth. So it needed a two-step approach. I was going to do a very thick connective tissue graft, but in conjunction, she was going to have a provisional made that was going to go in and kind of push this tissue to help guide this papilla back. This is an immensely challenging procedure because you really have very little bone to help support the graft, but with a combination of a good provisional and a thick graft, it'll help guide it back. All right, so here we have somebody that has recession. I get this a lot. They have recession and abfraction lesion. What do you do? Should you treat the abfraction lesion or should you send them to the periodontist to see can they get the root covered? So for me, I would say send them to the periodontist to see if they can get the root covered. So let me show you here. So here's the recession that she has. And a lot of times I'll take a diamond burr and smooth these abfraction lesions. And then this shows my incisions for connective tissue graft. I'll do like full thickness flap with the papilla. I'll clean the roots. I'll decontaminate them with tetracycline or my laser, and then I use a connective tissue graft, kind of like I showed you, but I add platelet-rich fibrin to it, which accelerates the wound healing. And so in this case, this is the before and after. So I got 100% of the root covered. Had I not, or had the abfraction lesion been an enamel, which connective tissue won't stick to, then I would have asked my restorative doctor to go back and add, a smaller composite there. So always if you have abfraction lesions and recession, refer them to your periodontist, see if they can potentially get 100% root coverage without you doing a composite. So I get a lot of second opinions in my practice, whether it's good or bad, but here is a patient that lovely, lovely lady who was referred to me from Duke. I'm like 20 minutes from Duke. She had had 3 biopsies done on the facial of 7 because she had recurrent inflammation like that. And 3 biopsies resulted in all this recession, as you can see. And the biopsies were not done by oral medicine, they were done by a periodontist. So here she is, and this is the final result that she showed up to me. You can see there's no attached gingiva. There's an implant here. And let's look at the coronal view. Here's the periapical. So I said to her, has your implant always been that far facial? And she said, no, girl, I'm glad you asked me. No one else has, but it's moved forward. So the inflammation that everyone was recording on 7 was really because 8 was failing. The implant on 8 was failing. So My plan with for her was to take out 7 and 8, and I told her I have to try to reconstruct the soft tissue, no matter what she did, whether a bridge or an implant, soft tissue here and the bone. And my plan was to do two procedures, two grafts and two bone grafts, and two and another connective tissue and another bone graft. So the classification system here, this is a Siebert type 3 because not only are we missing soft tissue and bone coronal apically, but occlusogingivally. And I said to her, probably we'll do one implant and cantilever one off. So I was going to try to do an implant in 8 and cantilever off of 7, or 7 and cantilever off of 8. Or a bridge, which would have to literally be from 6 through 11 in this case, but just to reconstruct this volume. Another thing I want to point out here is look at the lack of vestibule. So in my career, I have learned if you have no vestibular depth, no matter what you do, it won't last. So part of my procedure was to reestablish a vestibule like she had here. And so here it is. I took the implant and the tooth out, and this is the defect that I'm facing. It's kind of hard to tell, but it's a significant amount of attachment loss. And I did particulate bone. This is my PRF, and this is my connective tissue graft. So all that is in here. This is my connective tissue graft. PRF is here. My vestibular incision. This is surgery number 1. And here is surgery number 1 healed. And now we're going to go back and do a second stage because I told her she would need 2. Because I got my vestibule and attached gingiva, but now I need to build this height. And I did a second surgery exactly like I talked about. So this is after her second surgery, again, a vestibular incision. And she has a provisional. She has a really lovely, actually removable provisional. And a lot of my restorative doctors allow me to scan the patient, and I help design the provisional with the lab guy. It's, like a flipper, but she has a ball clasp. And as you see, it's a little shorter than the adjacent tooth because I don't want any pressure on it going in excursive. And so I'm thinking everything's going great. So she calls me and she's gonna go to a new dentist that her nephew works for because she can get an implant, a discount on the implant. And I'm like, are you kidding me after all that I did? And I said, that's great. I'm happy for you. I'm here to support her. And so he sends me these photos. So you're looking at the ridge that I reconstructed. Look at the amount of attached gingiva. Was I hurt? Yeah, I was, but I got over it. And this is his photos. He asked me like how I was able to grow the bone back. And I told him, this is to me a big no-no. You don't put this is his photos. You don't put a periosteal elevator against the body of the implant. But that's his photo. And this is her closed up. So she's in the process of getting that done with him. And, I feel really good that I was able to get her to the point where she could have 2 implants and a vestibule and a soft tissue that she lacked. So the next case is really, really interesting case, side story. So this is a lovely patient that lives out in the country in North Carolina. I live in a rural part of North Carolina. And this sweet woman was coming out of her driveway, turning right with her 2 kids in the back. And a dump truck does not see her and comes and hits her back. One of our children was killed, and she had multiple injuries, including a fractured teeth and a closed head injury, multiple broken bones. So after all that healed, she wind up at the dental school because, her teeth, she has a malocclusion, and she had ortho done. And this is her orthodontic workup. You can see how the teeth were pushed facially. And here she's having ortho to correct the malocclusion and get the overbind overjet. So this is how she was finished up by Dr. Tate Jackson, who is an orthodontist at UNC. And she went to see a prosthodontist who I work with, Dr. Lim, and he sent her to me. So if you look here, she has obviously uneven gingival margin. This was the tooth that was broken. Nothing lines up. So he sent me her case, and in order to mock up what he wanted me to do, he gave me this surgical stent. This is really a great way to communicate with your periodontist. Again, this is just clear communication where you have a surgical stent. He shows me what he wants me to cut away. I mean, I can do it without it, but it's just so good for us to be both on the same page. So here it is. I did a full thickness flap on 5 through 12, degranulate. I used my stent that he gave me, and I found the CEJ, followed his guidance with the stent, put the stent back on, see if I needed to scallop or recontour any more bone, and then sutured. So this is her during her surgery. You can see she has buccal exostosis that I had to get rid of. I had to like flute all this in. And then here, see if sutured close. And then here is his photos where he's doing a cast post and core on that case. And then here's her provisional. The provisional is highly polished. You've got the contacts that you want because you're trying to guide this papilla back. And this is his crowns on the lab. And this is her final restoration. And I must say the aesthetics, I think, were very well done. The color is great. She's sweet woman. She got a massive settlement from the dump truck company, but she's can no longer take care of herself or her children. And this was just a really nice case to get her to where she was able to smile again. But she had a closed head injury and could no longer take care of her toddler. So this is before and after, and it's just a lovely result. All right, so let's talk about implants. These are some important information that you should take down. How much do you need between the teeth, between the opposing arch and the implant? So in the anterior, you need about 9 millimeters. In the posterior, you need about 7. For a complete denture, you need 12 millimeters. So what I'm saying is you take a probe, you measure from the crest of the bone to the opposing incisal edge. This is how much you need for the anterior. This is how much you need for the posterior. If you have less than 7 millimeters, you better try to use a screw retained crown and or recontour the opposing. For a fixed hybrid, you need about 14 to 16 millimeter, which is quite a bit. And that's why a lot of bone is being taken away for these fixed hybrids because you need the space for the restoration. All right, so this is just a little blurry picture of an emergence of the implant in the cingulum. You can either look for a screw retained restoration with angled abutments or a cemented restoration. So this is a case where a patient was sent to me to uncover the implant. But again, going back to my years as a restorative dentist, there's no way on God's green earth that this could be restored because, yeah, you can get the impression, but how are you going to seat a crown and try to get through this contact? The implant's very high and it's too close to this root. So what wound up happening here is that the implant was left to sleep as it is, and the patient had a Maryland bridge. So these are some guidelines for implant placement. And again, implants are restorative driven procedures. So if you want your implant to be, if you're not doing your own implants, if you want your implants to be in a certain place, you need to communicate that with your restorative with your surgeon, whether it's by making them a guide, by having a conversation, by having a diagnostic wax up. But really, you as the restorative doctor drive this procedure. So here you are. The implant should be centered between the two teeth. You want to be 1.5 millimeters away from the adjacent teeth. You want to be 3 millimeters away from each other. Like side by side implants, you want them to be at least 3 millimeters away from each other. That way you can get the papilla back. Otherwise, you're squeezing the bone, you're squeezing the papilla out. All right, so let's talk about implants in tight places, congenitally missing teeth. The first case I'm going to show is an absolute true story. The patient was congenitally missing 7 and 10. She had ortho done and moved from Atlanta. She was a malpractice attorney. So was told by the orthodontist, when you get to North Carolina, find a periodontist and have them do the implants. So we get her in, and I do a CT scan. And as you can see here, this is Simplant software that I was using to plan. There's literally no bone on the facial, which is okay. We can try to regrow that. But interproximally, you see I have no room. I don't have the 1.5 millimeters between these roots. And you see her roots are already shortened. So I was like, I had the bad news of telling her that she's going to have to go back into ortho. So lesson here, if your patient's having ortho to open spaces for congenitally missing teeth, before they debracket them or stop the ortho, send the patient to you or to the surgeon for them to take a periapical or a CT scan to see how much room that you have or what you need. So in this case, I didn't have the room, and I said to her, you probably need to have ortho again, which of course made her very upset. The messenger was not heard, but the message was upsetting to her, and she started crying. So I said, well, let me send you to a prosthodontist, see if we can work something around this. So, and this is the periapical view. You can see that clearly I don't have enough room for even the narrowest implant. And I use Straumann, which is the narrowest platform they have is a 2.9. And I'm not going to use a mini implant here, but I'll talk about that in a second. So it's either live with the Maryland bridges that she has, or if she wanted to do implants, we had to come up with a different plan. So I sent her to the prosthodontist, who was a very wise person to work with. And he said, look, here's our option. You either do ortho again, or we take out 8 and 9, put the implants in 8 and 9, and cantilever off of 7 and 10 off of them by splitting them together. So this was a 3 month fix versus another 2 years fix. So she opted for that. And 8 and 9 were not, there was nothing really wrong with them. But as you can see here from the cone beam, the roots are significantly shorter than they should be. So she agreed to that. And I brought her in and did extraction of 8 and 9. And I did immediate implants. So here are my implants. And I did a pretty broad, they're both like 5.0 by 11. Um, and here's her final restoration. So 8 and 9 are splinted. This is a cantilever on 7 and a cantilever on 10. And I think I have a better view. So this was able to resolve the problem. But lesson learned here, if your patient's having ortho because they're congenitally missing a lateral, first of all, we need to talk about the timing in younger patients. Two, if they're missing a lateral, it's better to try to get the canine into that site and then develop the site where the implant could go and where 11 used to be. So you make 11 a lateral by recontouring the tooth and then try to place an implant distal. Trying to regrow bone on the facial of 710 is not a slam dunk. It's pretty challenging. You can do a block graft, which I don't do because a lot of those tend to not take, or you can do particulate, which is like bone grafting with, bone from a bone bank. So let's talk about, here's another case. The patient had ortho, and this is a 2.9 implant Straumann. If you go to some of my other lectures, I'll talk about why I use the Straumann 2.9 versus the Astra 3.0 or Nobel 3.0. The Astra and Nobel 3.0 can only be torqued to 15 newtons, which is a very low amount of torque. That's basically what you can do with your finger. Whereas Straumann, even though it's a narrow one, it'll be torqued down to 35. And nothing is more disheartening than you taking the healing abutment off and the whole implant spins out. And that's why I use the 2.9. And that's the indication for the 2.9 Straumann implant is a congenitally missing lateral. So this was a photo of that little guy's case, and aesthetically, he was very pleased. So in contrast, I have this patient. She was referred to me by her restorative doctor. She moved from Pennsylvania, and they said, Hannah, can you cover this white thing? But as you see here, these are mini implants. If you look at this view here, the implant is literally outside a bone. It's just in soft tissue. I'm sorry, let me go back. It's on the facial of the ridge. It's not in the ridge at all. Both of them were like that. So Um, she was in college at in Pennsylvania, and that's where she had these implants done. So you can see she probably could have had a conventional implant, would have been tight. So I said to her, I'm going to open this up and see what that white thing was. And the white thing was actually the fixture mount on the implant and that's what she was referred to me for. It was to see if I can cover that recession because it was catching food for her. So I removed that plastic housing and here you could see how many threads are, I mean, basically the whole implant was out of bone. So I did a connective tissue graft and PRF. And I said, look, when you get out of school and fall into a bucket of money, come find me because she was from North Carolina, and we will go from there. So guess what? She found a bucket of money. She is now an ICU nurse and she comes see me. I said, well, in order for us to do anything, these implants need to go and you need to have braces with IPR to make some more spacing so that these can be brought into alignment with the rest of the ridge. And here are the implants that came out, and you can see the ridge lap here on the crown. So I took them out. I did bone grafting, connective tissue grafting, and PRF. And here's my PRF. Here's my connective tissue grafts, and stuffed all that in there with a bone graft. And then here she's doing ortho. And if you, she's still in ortho, these roots need to be like, this needs to be moved distally and this one a little bit that way. But you see, we're starting to gain the space to have the crown in the proper alignment as the rest of our lower incisors. And this tooth was turned. So it took several years to get there, and she's been very patient, but she realized that she wanted something better than what she had. Okay, next case, truly an endoperio or perioendo lesion. So you'll get these cases, you don't know, they have an endodontic component and a periodontal component. Where do you send the patient off first? Well, that depends on the relationship you have with your endodontist and your relationship you have with your periodontist. So at the beginning, I said you need to get, like I have my go-to endodontist, I have my go-to oral surgeon, and I have my go-to orthodontist. My oral surgeon is 45 minutes away from me. And the reason I choose him because he's number one, dual boarded. He's a oral surgeon and an anesthesiologist. And he and I share the same philosophy. Same thing with the endodontist. So find those people and keep them in your pocket because things will come up where you need them. It doesn't matter if they don't give you cookies or whatever, as long as have your back. That's what means more than a crumb cake or a bundt cake. So this patient, again, was self-referred as a second opinion because he wanted to save his lower incisors. So I am in a small town, but a lot of the patients are, doctors and physicians at Duke or UNC. So they really research thing on Google. And so they come in with, a bazillion questions. So this guy didn't want to lose his lower tooth. He'd had the swelling on and off. General dentist told him to take it out and do an implant. Let me step back and say, if you lose a lower incisor, you better stop and look at the remaining incisors because, first of all, trying to throw an implant into this bone, the implant crown would be this long. So aesthetics would be a consideration, function would be a consideration, and you really need to have all that worked out before you decide to take this tooth out. And he said he wanted to save it. So in my mind, this is a perioendo lesion. So I treated him with laser surgery. We talked about taking out 23 through 26 because remember what I said. When you lose a lower incisor, you better stop and look at the remaining lower incisors. Is it better to put an implant here and an implant here? But remember, he had bone loss right here. Is it better to take this out and do like a Maryland bridge? It would be a single wing Maryland bridge, and I'll show a case. Or we're going to try to save it because that was his desire. So I did, we're going to try to save it. I did the perio surgery with a laser. You can't really flap this open. If you flap it open, the tissue will recede down to here. So I did a laser assisted surgery with PRF in that site. And let's look at our results. Oops. Uh, sorry. That, So what I wind up doing that day is just using my Nd:YAG portion of my photonal laser to remove the debris, the granulation tissue or the epithelium. Then I cleaned with instruments that come, like the Cavitron or the erbium. Then I tucked in some PRF. I cut it up into little strips and put it in there. And here's this 2 week post-op. We took an X-ray just to see. You could already see bones starting to fill in. So then he went to his new general dentist, and I said to her, "Can you please do endo and splint these teeth, like connect them from 22 to 27 with the lingual splint?" And this is her at 4 weeks, and you see again more and more bone fill. And this is a beautifully done splint. He had a little setback in that his pocket on the facial came back because he had an over-the-counter mouth guard that he decided he didn't need to wear. So we're like, no, no, if you want to save this tooth, you're going to have a conventional mouth guard and you have to wear it all the time. And here we are. This is 6 weeks later. Minimal recession, bones filling in. Remember, this tooth had no bone around it. So combining the treatment of perio endo, ideally, probably you should have had the endo done first, but the tooth was so mobile and there was so much drainage, we didn't think it would work. So I did the perio first. So here we are before and after. Um, Here is a another case, a second opinion. This is literally one of my most challenging cases I've gotten in my career. So this is a patient who happens to be a TV anchor here in the Raleigh-Durham area, and she had 7 and 9 extracted with immediate implants and immediate provisionals by our oral surgeon. So the aesthetically, it was incredibly unesthetic for her, in that her teeth were really long. So she was sent to me to see if I could address the inconsistency of clinical length of these teeth. But let's go back and look at her x-ray. So the implants are about 10 millimeters from the CEJ of the adjacent teeth. So they're way, way, way too deep. So my first step was like, well, we need to talk about taking these out. We either bury the implants, which means take the temporary off, put cover screws on, and just go back to a good old-fashioned bridge from 6 to 11, or try to remove the implants, graft the site with bone and PRF and soft tissue so that you can have either repeat the implants or go ahead and do a bridge. So she decided she wanted them removed. And so I literally, I trained on Nobel, but I called the manufacturer and found the guy who invented the implant removal tool for Nobel. And I said, look, I sent him the x-ray and I said, can I put an extender? Because remember how deep these were. Extender on this so I can remove these. He said, no, you can't put an extender on the implant removal tool because that exceeds the torque capacity of that tool and you'll break that off in the implant. So you're just going to have to try to find a way to get these out. And, my plan was to grind these out, but as you see, it's just very challenging. You don't want to take as much bone away especially if you're trying to do implants again. But lo and behold, I was able to get the implants backed out, and here they are. And so I did the thing I talked about before. I did a bone graft, a connective tissue graft in each side. I did my vestibular incision, and I did PRF. And then here is her provisional. This is a removable prosthesis that I designed for her. We scanned it in the office, and I sent it to my lab guy, and he sends me a digital mock-up. So this is a removable appliance, and you see the class. I thought it was an excellent result. Let her heal for about 6 months. Then I went back and placed, this is my Straumann 2.9, my Straumann 3.3, and she had these are my implants, and then here's her bridge. It's not perfect, but it's better than she was before. Her chief complaint, honestly, was more that these teeth ached because she had a relative infrabony defect. By that I mean the bone on the adjacent teeth on 6 and 11 was not on the same platform as the implants. So let me show you this, what I'm talking about. This bone here is like, why am I here when the implant bone is up here? So this is an infrabony defect. This is an infrabony defect. And it's again almost like a biological width violation, and the bone on these teeth was remodeling. So getting these out was not only for aesthetics, but also to try to save the adjacent teeth. Okay. And I have funny stories about her. Maybe I'll tell you during the break. So this patient was sent to me by a prosthodontist, extremely attractive lady. If you can see here, she does not like this. So he's like, can you take this implant out? It wasn't my implant. It was done like 10 years ago. And this, she said when she smiled, she felt like this was a headlight right here. So when I take it out, I said, well, can't you work with this? He said, no, this is the angle of the implant. The implant's very, very facial. And so that's the access point. Probably if it was me restoring this, I would have done a cemented restoration or used an angled screw abutment, which may not have been available for Zimmer at the time that this was placed. So the only option we had at this point to improve her aesthetic was to take the implant out. So I took it out, and which was not easy. I have two kits that help me remove implants. One is the Zimmer case kit, didn't work on this at all. The other one was the Salvin kit, also didn't work. So I basically had to take away just a thin plate of bone on mesial, distal, and facially and like muscle it out. And then she had a single wing Maryland bridge. This is the new thought. You don't do two wings for a Maryland bridge. You do a single wing because there's less flexure and less likely to debond. So this is her single wing Maryland bridge done by her restorative doctor. And this is my new Straumann implant, which was a 3.3 by 12. And then this is her final restoration. So this is a case where implants have gone bad. What is the problem here? I wish we had a live audience. I can like ask you guys questions, but in this case, this is a young lady who's in medical school. She's about to finish at UNC and move away to start her pediatric residency. So that what the problem was is this implant was done before she finished growing. So her midface grew down and the implant stayed up. This implant was done when she was 18. So you really, really need to wait on implants in growing uh, teenagers, women and men. My nephew, when he went to high school, when he went to college, weighed was 5'11". When he finished college, he grew to be 6'11". So boys, you wait even later than girls. And there's many ways to certify that they're done growing. You can go to the orthodontist and ask them to do a ceph 1 year apart to see if the AB line has changed. If they're unwilling to do that, some people use wrist films, wrist x-rays. It's not as reliable. And if I can't get the orthodontist to give me if they're done growing, what I'll do is I'll go to the pediatrician and say, can you tell me if they've consistently stayed on the growth curve? Have they been in the 95 percentile for the last 2, 3 years? But in most patients that I get that are young, I honestly will wait till they're in their mid, 21, 22, 23 to do an implant. I no longer will do an implant on an 18-year-old girl. They're just not through growing. So I took her implant out and you see where the implant is. So I had a soft tissue defect, again, another Siebert defect to correct, bone and soft tissue. And there was really no bone at all on the facial. And she was moving away. So we decided to do a single wing Maryland bridge. So this is, again, after I removed it, I did a connective tissue graft. Here's my vestibular incision. And here she is with her single wing Maryland bridge temporary. And I think that's her final restoration. I never did I never did get to see her because she was moving to start her residency, but that's a whole lot less ugly than what she had before. And she was really, she said, thank God COVID happened because I was able to wear a mask, but I'm a pediatrician. I have to be able to take my mask off to talk to my little patients, and my tooth is embarrassing me. So once she gets settled, I think she can try to do an implant, if not live with a single wing Maryland bridge. All right, next case. This is actually one of my patients, a really interesting situation. I just wanted to give everybody some information so they can learn in their practice. So this is a 62-year-old female, and I diagnosed a squamous cell carcinoma in the pharynx. What she was on maintenance, and she came in, she had like a little ulcer in the pharyngeal wall. And I said, oh, she's like, oh, I like used hot cheese. I said, well, come back in 3 weeks. She comes back in 3 weeks, and the lesion's 3 times as big. So I happen to have in my pocket the ENT that I worked with. Again, you just have to have this group of people that you can turn to immediately. So I got her in with the ENT at Duke, and he's like, oh, Hannah, this is nothing. I think she's fine, but let's get a PET scan. So they get a PET scan, and the lesion is extremely large. It's in all her nodes on the left side, and she was a smoker and a heavy drinker. So he sends her for radiation to shrink the tumor down so that he can remove it. But she had an implant in the area of 19. So I wrote a note to the radiation oncologist to please shield my implant so that when she has the radiation, that energy isn't transferred directly to the implant and cause osteonecrosis. And of course, they didn't do that. So here you have, after all her treatments, you can see how the bone is just eaten away from that implant getting heated up, including here. And literally shielding the implant, all it would have taken would have been a cotton cotton roll in the vestibule here and here to so that the energy that's directed at the lip and the cheek isn't transferred directly to these teeth. And so that didn't happen. And this was an incredible journey of 5 or 6 years to try to correct this. And then I had to take these teeth out, and she had to have hyperbaric oxygen treatment. And that's another story. Um, and then she wound up having I placed the implant, but I treated her with my laser with photobiomodulation. And over time and PRF, we got bone to come back. And then this is her prosthesis for the upper. And let me just show you, this is 2 years of me treating her with BioStem and PRF, and you see the change in the bone over the splint that they did. This all filled in. I didn't do a bone graft. I just did photobiomodulation or BioStem and PRF to try to get this to grow some bone back. Her mouth was really scarred down, very challenging because of all the radiation. But if you can learn anything from this, is that before someone starts radiation, you got to look at everything they have. If there's any question, take the tooth out before they start. So here's the before and the after. Again, no bone grafting. I just did literally photobiomodulation and platelet-rich fiber. The photobiomodulation was with my laser. So let's talk about ponic development. This is a great picture to take, slide to take a picture of. You see what I ask for is a conical ponic, a ponic that looks like it's emerging out of the socket. You really don't want a saddle or a ridge lap. You want more of a modified ovate ponic where it pushes into the socket. It looks like it's emerging out. And this is just from an article. You can use a round diamond burr once the soft tissue is closed to develop that ovate shape in the soft tissue. So here's a case of that. This is a patient who was going to have number 8 extracted and was sent to me for ridge augmentation. She wasn't going to do a bridge. She wasn't going to do an image. She was going to do a bridge. So this is what a connective tissue graft looked like. So I did a connective tissue graft with a bone graft in the ponic side because I want an ovate ponic. So this is her healing with the provisional. And yes, you could say a lot of not so good things about the provisional. But thank God her tissue type was more forgiving, and this is her final restoration. it literally looks like this pontic is emerging out of that site. Okay, let's talk about root resorption. For some reason, there's a ton more root resorption than there has been. I don't know if anybody else has noticed that, but um, that's when you have the loss of hard tissue, cementum and dentin, as a result of odontoclastic action. And the root resorption is associated with primary teeth is desirable because it results in exfoliation of teeth, right? It's how the baby teeth are lost. But in a permanent dentition, it causes irreversible damage and eventual tooth loss. So this is a classification system, and there's another one from Europe, but we'll just go with this one. Class one, where it's incipient. Here's class two, it's getting worse and worse. So the worst kind of resorption that you can have is external root resorption because it usually emanates from the sulcus or the periodontal ligament, whereas internal, you can have the root canal done and that will arrest it. But external is immensely difficult to arrest. Predisposing factors for external root resorption, orthodontic, usually bruxism or trauma, developmental defects, intercoronal bleach. So like if you're bleaching a tooth for because it's dark, um, surgical procedures. I've seen it honestly sometimes with free gingival grafts. The patients had a free gingival graft many years ago, and they've had tetracycline or citric acid to clean the root. You'll get some external resorption, but 15% of the external root resorption are idiopathic. We don't know why it happened. So it occurs immediately apical to the epithelial cervical region. The damage to the protective cementum below the epithelial attachment exposes the root surface to osteoclasts, which then resorb the dentin. Microscopic analysis show gaps of the cementum in this area, leaving the dentin exposed. So usually you'll have like granulation tissue growing into it. The patient will say it's sensitive or the gum is red when they brush or floss, it hurts. It's usually a chance finding on the radiograph. So I've unfortunately we've seen like a really big uptick in external resorption after COVID. Not sure why, but like in the past week, I've taken out two incisors that had external root resorption on the lingual, making them unrestorable. And the early lesions are usually radiolucent in appearance. Advanced lesions are mottled because it becomes a fibrous osseous nature of the lesion. Um, so let's go through some cases. Case number one, you have a radiolucency distal to number 9. It's asymptomatic. Again, it's found on coincidental on examination. The gingiva looks normal. The pulp is vital. So the differential diagnosis is caries, root caries, or external root resorption. In that case, it was external root resorption. So this patient really wanted to save his tooth, so I opened it up. You see how there's all this granulation tissue. And so you clean it out. Your options are this, take it out, do a bridge, take it out, do an implant. Two cases that I did this week were unrestorable because it literally like hollowed out the lingual, and I did took out 8 and 9 on two different patients and did immediate implants. But in this case, this patient wanted to save it. So we open it up. You can see it, you can patch it with amalgam. Not many people are going to tolerate that in the anterior. In my case, I use like a glass ionomer. I used to use Jerry Store when I was in residency, but I found that very rarely does the soft tissue stick to it. So I'll use Ketac Sem, some fluoride releasing material. So here it is open, and here it is with Jerry Store, and then 1 week post-op. Next case, this is in the area of 20. It's on the facial, so it's much more accessible. You can see here the probe falls into it. Open it up. Very, very reachable. Endo because it was into the pulp. Cleaned it out. Restored with glass ionomer. Sutured back up. Do you see how much better it looks than a Jerry Store? It's like pink and firm. The tissue likes the glass ionomer is a lot better than Jerry Store. So the take-home message is that external root resorption is usually asymptomatic. It's just an incidental finding on radiographs. If the patient wants to save the tooth, you've got to look at opening it up, patching with a glass ionomer. Tell them that eventually will fail, but I mean, like everything we do will. Larger lesions, you can watch until they're ready to have it extracted or they become symptomatic. And then you talk about replacement, whether it's an implant or a bridge. This last case, I think, really, really describes the failure to communicate and plan on my part and on the prosthodontist. And I'll just show you my mistakes. I'm being completely honest. So this gentleman, again, I live in the country. He is a sweet man. He worked a second job in a factory for 2 years, cleaning the factory so that he could afford his dental work. He had orthodontics done to open his bite. He was missing 8 and 9. This is the clearance he got from the orthodontist. So he was referred to me by the prosthodontist to place implants in 8 and 9. As you see, the space is rather large. So in my mind, I asked for a diagnostic wax up to see how big these teeth are going to be. And this is what I got, a photo of models with beadwax and denture teeth. So I wrote back and I said, this is your diagnostic wax up. You're okay with this? And he's okay with this? And I said, yes. And I said, you're not going to close the space here or here. No, we're going to leave it open. He had a space before and he's okay with it. So my mistake is I should have put the squash on that and said, no, I really feel like you need to do a diagnostic wax up because look at his occlusion. Look how tight this is. We needed like either a diagnostic wax up, whether it was a real one or virtual. And my mistake, I should have said no. So we moved on, looked at his occlusion. Like I said, he had ortho done. The space between 8 and 9 was 24 millimeters. So normally you want centrals to be 7 or 8 millimeters. So total of 16. So we had about 8 millimeters extra. And there's minimal interarch distance. So this is how this is the pre-op panorex from his general dentist. Again, communication was really, really poor on this case, including on myself. He was referred to the prosthodontist after 8 and 9 were taken out. But in the meantime, 13 and 14 were taken out without any conversation with me or the prosthodontist. They were just taken out by the general dentist. We don't know why. So I get him in, I place my implants, I do my workup. Here's the guide that she gave me, which is right here. It's basically a suck down. And she asked me to recontour the lower teeth. And I said, I feel like that's maybe more like in your wheelhouse, but I'll gain you some room by recontouring the bone, but not enough to not put a proper length implant. So I did that. I reflected the ridge. Remember, we talked about how much space we needed. I needed at least 9. So I got my 9 and I'm measuring. I placed my implant. This is my osteotomy site. These are my implants. Here's what they look like, well healed in the middle of the ridge. We were going to keep spaces here, right? So he like disappears. I don't see him. So I call the restorative doctor, the prosthodontist, and said, hey, can I see where he is? It's been like 4 months. So she sends me this photo. She decided to do screw retained crowns and close the spaces, even though initially we talked that these spaces were going to be open. Well, that is a very large central. And look at the blanching that he has here. So really, in this case, there was no reason for them to not use angle screw channels and or just do cemented restoration. So this goes on, and he's sent to me because he's now having pain on the facial of the implants. Well, you saw the provisional, it completely crushed the buccal plate in both areas. So this is the x-rays we take. And now, but this one implant is failing. This is at the time of uncovering, and this is what it looks like now. So I wind up taking this guy out, and I said, look, I need you to get a diagnostic wax up done to see if we even can redo his implants. So we get it. This is me scanning him in, and I sent it to the lab. And this is the implant. You see how much bone loss there is on it. So the lab does a digital mock-up, and in the digital mock-up, look at the occlusal pattern in excursive on these teeth. So they said, no, he cannot have implants. There's not enough clearance. So unfortunately, I wind up taking both implants out. And to tell you the truth, I gave him his money back because I felt bad for him. The guy worked 2 years in a factory to afford this. So the key here is to communicate early and hard. If you need to step back and do a diagnostic wax up or a digital mock up, it's the best thing because communication is key. And I should have said no once I saw that handheld model. I should have said no, I'm sorry, we need to have a digital mock up. But I was working with a prosthodontist, but still, there's no excuse for it. We really should have all communicated a whole lot better because I felt like this guy. Now he's got a partial. He doesn't even have something fixed. He's got something removable. So this is my information, and thank you for taking the time to meet with me on a Saturday morning. If you need to send me any questions or whatever, this is my Instagram, my cell phone, my email. And this is me in the Cayman Islands in end of August. It was one of the beautiful places I've ever been. This is me and my staff. We went out for ice cream in the fall. So I'll take any questions on if somebody has any.
All right. Well, Hannah, Dr. Hobbs, thank you so much for an amazing, amazing lecture. It's always a
Yeah.
privilege to hear your expertise. I do want to take a moment before we start questions to give a shout out to Dr. Bellamy, our current National Dental Association president, and Dr. Newsom Dobbins, who's our president-elect, both who have graciously joined us on a Saturday morning to watch your amazing lecture. Yeah, if anyone wants to raise their hand, we can give you the microphone so you can ask your question, or you can drop it in the chat, whatever anyone's preference is.
Dr. Horton, we did have a question while Dr. Hobbs was lecturing. Dr. Hobbs, I sent it to you directly, but I can Dr. Horton, if you don't mind asking that question, I'll send it to you as well.
Is it on the chat? Sure.
Let's see.
It was my question. I don't mind saying it out loud.
Oh, yes, yeah, go ahead.
Okay. Hi, Dr. Hobbs.
Hi.
When you were talking about the abfraction lesions and communicating with the periodontist maybe first before restoring them, how could we properly communicate that on a referral?
That's an excellent question. So on the referral, just say, I notice these subtraction lesion, how deep they are. Do you feel like you can cover these with your graft? Or should I try to do a composite or wait till after you do your grafting procedure? Then I will see what's left to restore. If it's an enamel, they're not going to be restored. They're not going to be covered by the graft because enamel connective tissue won't stick to enamel. So if it's half of it is in dentin, half of it is an enamel, you're going to need to do the enamel composite after the graft is done.
Makes sense. Okay. Thank you so much.
All right. I think I can actually ask a question. When I was listening earlier, I was curious as to which of the many PRF protocols that you are using these days.
That's a great question. So we just draw like 4 ml. So I use PR platelet-rich fibrin in every surgery that I do. Connective tissue graft, bone grafting, laser, extraction, implants. So I usually just draw 1 or 2 tubes. It's rare for me to draw more. Spin these down. My assistants do that. And I draw my own platelet-rich fibrin. I draw my own blood. It's really not that hard. And actually, I'm going to shout out for the AGD. I'm giving a course on how to do platelet-rich fibrin here in North Carolina, if anybody's close enough. I honestly I'm sure you feel the same way, Dr. Horton. It really improves the healing. So I let that spin, I do whatever I need to do, and then we'll put it in that plate, have it squished down. Sometimes I'll do sticky bone, but most of the time I'll do particulate, and then I'll add the connective tissue, the PRF as a membrane on top. Does that answer your question?
Absolutely. Thank you so much.
We have a question from Dr. Bellamy.
Yes, first of all, thank you both, Dr. Hobbs and Dr. Horton, for hosting this forum for our dentist. I really appreciate that. I did have a question here. This is the first time I've really heard about your protocol for moving the cuspids into the lateral space in order to gain bone volume, and then do the implants into the cuspid space later when the children have reached a determinate age. At what age do you consider doing that?
So this is a technique that Vince Kokage, I don't know, are you an orthodontist or?
No, general dentist.
So Vince Kokage was this really profoundly important orthodontist in the Washington state, right? Dr. Horton, but he passed away like a few years ago. And that's what I learned in my residency is that, if you're congenitally missing a lateral, it's just really, really hard to regrow that bone. But with orthodontics, you can drag the root forward. And by doing so, you can help move expand the bone, and then you can deal with the distal of 11 later. And so I honestly now will wait for implants till like the person's in their 20s. It's very hard for me. I used to place them when the girl, especially in girls, because I thought they grew sooner at 18. But as you saw from that case, I've gotten more and more shy from that. And I'll place them when they're in their mid 20s, like 21, 22, 23, boys later than girls. And it's really hard because they want a tooth. That's the whole reason they're doing the ortho, because they want a tooth there. So if you move the lateral and the canine into the lateral position and make it into a lateral by shaving down the incisal edge of 11 or 6, you can buy them more time, but at least not their front tooth. I know that's not a popular opinion, but it's just very challenging to grow the bone that's congenitally missing. And I used to I used to do block grafts, stopped doing those. And then I would send them to the oral surgeon, and several times I'd grind into a site that had a block graft, and the block graft would fall off. And there's a lot of complications with having a block graft. I'm going to show them in another lecture where the tissue's coronally repositioned to cover the block graft. So the mucogingival junction is not the same on the centrals as it is on the laterals. And then they have very short clinical crowns. So I would prefer, based on Kokage's technique, to move the canine into the lateral area and then have that space distal. Or even if you can close it all together with ortho.
Interesting. I appreciate that. Thank you.
Look up Vince Kokage. That was his technique. He
Oh,
also
I'm familiar with Kokich. I'm familiar with his work there. I just had never heard of that particular technique, and now it's going to make me think very, very differently on congenitally missing laterals.
It's one of the hardest things to do, and I was involved a little bit at UNC with auto transplantation. I don't know if you've seen that.
I am.
I've had a couple of cases. They've actually worked out okay, but you really have to have like a team there to make that work because you're doing a 3 digital mock-up of the site, and then you're taking the tooth out as atraumatically as possible, usually like a lateral bicuspid, and then rotating that into that. Then the tooth is splinted, the lingual cusp is removed. So my daughter is congenitally missing 20, and her pediatric pedo ortho is Dr. John Christensen, and he wanted me to take out 12 and put it in 20. And I was like, yeah, John, I'm not doing that. I'm I'm just gonna wait till, something comes along where I can squirt, a gel or a growth factor into that site and grow a tooth because her primary buy is still there and it's holding the space. It's not enclosed. So I'm like in my mind, I think that's still a little experimental, but maybe I should be more open to it.
Thanks.
Thank you.
Dr. Rogers.
Hi, Dr. Hobbs. I have one last question. I remembered when you were talking about the lateral canines and not being able to put mini implants in that area, but I don't know if you did mention why not for the mini implants.
Well, the mini implants are not really osseointegrated. They're not meant for the restoration will never have the emergence that you want. Not that I don't do mini implants. I do a lot of mini implants like OptiLock for a lower like a lower denture. I just think they're 2.4. If you can get more space to do a 2.9, you're going to have more osseointegration with more ability to customize the abutment and the crown. Whereas you can't really do that with the mini implant. It's like an apple with on a stick. It'll be over contoured and ridge lapped.
Makes sense. Thank you.
And I don't know, like I've been blessed with Dr. Horton asking me to speak at the NDA. I will speak about peri-implantitis and abutment selection, and that's a really big part of what I do with my restorative doctors, help them figure out what abutment to use in what case. So as a general dentist, I did not know that we had the ability to pick our abutment. We are leaving it to the lab, but most of the time the lab has like a setting that they default to, like setting 3. And sometimes you need a fully anatomical abutment in a molar area. That's going to make or break your case. If it's like a skinny abutment and a big crown on top of it, that'll cause peri-implantitis. That'll cause it to get loose and it'll hurt, or the embrasures won't be right. So maybe in that lecture, I'll talk a little bit about abutment selection because that's really, really key. And I didn't learn about it till about 5 years ago when I went to a course at Straumann, that I have the ability as the doctor that's sending a script to say, I want this kind of an abutment to tell a lab. Because usually the lab will just defer to whatever settings on the machine. It'll be like 3, which everybody gets tissue sparing, which will be like an apple on a stick. It's okay in the anterior, but not in the posterior.
All right, looks like
Great. We have a question in the Q&A. It says, what was the period of time to complete the 2-stage particulate bone graft in the earlier part of your presentation? Can you give us some of your general timelines, like after grafting, how long you wait,
Oh,
and then especially
like
after regrafting?
On that lady that went to the other dentist. Yeah, I waited like 3 months and then I went back.
So,
Sometimes I'll wait 4, but usually 3. I feel with the PRF, I enter my sites a lot sooner than most people. I usually enter at 3 months. And it's rare for me not to have type 2 bone. Very, very rare. So I
awesome.
enter, and on her case, I did, and I told you, like she went, but on a side note on her, so one of the implants failed. So now she's coming back to me for me to fix that. And I'm like, I'm kind of caught between a rock and a hard place. You either, stick with him or, when I come back to me, I can't be getting, you know what I mean? It's just a little tricky. So my staff is like, I mean, she's a lovely person. She went because her nephew worked there and she got a discount. But at some point, you got to make a decision which path you're gonna. I'm like caught between her and him and whatever. So we'll see. And that case, the lady with the implants that are really high. The funny thing I want to tell you all. So she's on the TV crew here, like one of the evening television people. And somehow, when she was at my office, she checked in on Facebook. So we had like all these messages, people praying for her, like hundreds and hundreds of messages while I'm at work. And I'm like, our receptionist, I'm like, our Facebook page blowing up. I'm like, what's happened? Well, somehow she checked into my office on Facebook and said that she's having surgery. So all these people were like signing in saying, oh, wish you luck, blah, blah, blah. It was just kind of funny. I don't think she meant to do that, but it gave us a little notoriety. Just on a side note. So,
Okay.
yeah.
Well, since it doesn't look like we have any more questions, I want to make sure everybody remembers to fill out the survey, and Marcus dropped the link to the survey in the chat.
100%
Uh,
participation, all good.
awesome. Well, Dr. Hobbs, thank you so much for giving us your time on a Saturday morning. We appreciate any opportunity to learn from an expert, and you are an expert's expert.
No, I don't.
We look forward to hopefully potentially seeing you in Virginia. So if nothing else, this is a great primer for even more great content to come at our summer convention in Richmond, Virginia. So thank you, Marcus Ware, again for
Thank
facilitating
you
this and
all
giving
for
us the platform, and Dr. Bellamy for gracing us with your presence on a Saturday morning. So, other than that, I bid everybody a farewell. Have a good weekend. Get rested so we can tackle the workday on Monday.